I'm Becky Sprecher. I'm on the DIOA Board of Directors, and I'm chairman of the Government and Community Relations Committee. Welcome to our February Speakers Forum on the COVID-19. It's Thursday, February 11th, 2021. Three of our committee members are helping with this today. They are Dr. Bill Samuels, who is a retired psychiatrist, and Janet Bowden, who recently retired from a nursing career. Plus, we have our very own Zoom expert, Patty Overly. Before Bill and Janet introduce our guests, Patty's going to briefly explain how our viewers can ask questions using the chat feature. Patty?
All righty, thank you. Welcome, everyone. We really want to encourage your participation here. So if you'll follow along, please take your mouse, hover down to the bottom of your screen. There are going to be some controls that pop up there. You're looking for the chat button. Click that chat button, and to your right, a list of names will come up and an ability to type in a message. You'll see a little blue bar there. What I want you to do is take that little arrow, click it, and my name will come up. I'm going to change my name right now to questions so that you can know that is where you direct them. And then once Janet and Bill are finished asking some predetermined questions, we're going to absolutely get to yours. So I encourage you all, as the doctor is, or the doctors are telling us all of this wonderful information, go ahead and start chatting them in there. I'll be collecting them, okay? And then we will start that live Q&A at that point. Back to you, Becky. Thank you.
Okay, Patty. Bill, would you like to introduce our guest today?
Sure. Today we have with us Dr. Kurt Gambla from Beaufort Memorial Hospital. He is the first vice president and chief medical officer. He serves as the intermediary between BMH medical staff and administration, advocating for high quality, cost-effective patient care. He also helps to recruit new physicians and plan for strategic expansion and improvement. Dr. Gambla is an internist and has been in private practice with Beaufort Memorial Primary Care. Joining him is Dr. Emily Mayer, Doctor of Nursing Practice. She is the medical director of infection prevention at Beaufort Memorial Hospital, overseeing the therapeutics for all patients with SARS-CoV-2 disease, which is COVID-19. Emily is a graduate of MUSC, and she has an undergraduate background in public health. Dr. Gambla, Dr. Mayer, welcome to our Speakers Forum, and why don't you start educating us about COVID-19?
Thank you for that kind introduction, Dr. Samuels and team. Thank you for reaching out and allowing us to have a few minutes of your time tonight. I think speaking on both of our behalf, it's a privilege to be here. They don't let me speak in public unless I bring somebody smarter, nicer, and better looking than me. So that's why I have Emily with me. She hits all those boxes, and so we'll try to tag team this and see if we can't have a nice discussion about COVID and certainly answer any questions that you have. I will say this before we launch into the slides. As you know, if you're watching the news or talking to anybody, this is a rapidly evolving situation. Every day, the amount of information we have about COVID just grows exponentially. So what was true last week and what we talk about tonight may be a different story on some aspects or many aspects tomorrow. So keep that in mind, that what we're giving you is to date our sort of best educated guess on sort of the state of the union as we know it right now. And always look for sources of truth. There's a ton of misinformation out there, but your primary care physician, who should know you better than anybody medically, is always a good place to start. CDC website is a great reference. South Carolina DHEC is a great reference. So those are sort of three good go-tos in terms of any questions that you have sort of on an ongoing basis for this. But with that, we'll go ahead and start the presentation if you have the slides. Go ahead, next slide, please. So what we hope to cover tonight, just very briefly, is a quick review of what we think are some of the important milestones historically from the beginning of COVID as we know it till now. Few interesting statistics. Emily will talk to you about some therapies. What we know right now seems to work and not work. And then I'll come back on and talk a little bit about some highlights of just a few select vaccines, what's out there now, what we think is coming down the pipeline, and a few comments on the variants now that we're seeing identified in COVID. Next slide, please. So this thing started, hard to believe, over a year ago. First reported case, November 2019, Wuhan province, China. They are still uncovering the why and the how. We think that this was one of these things that we see from time to time that we don't know why, but a virus that is common in animals jumps to humans. And so that story, I think, is still being uncovered. But first case was then. We're over a year now in the US, coming up on our first anniversary in the state. And a little less than a year ago, the World Health Organization finally said, yep, this is everywhere. It's definitely a pandemic. Shortly after that, we saw our first case here locally in Beaufort. And shortly after that, we started to see the first, what are we going to do about this, in the first attempts in California to come up with some regulatory things that we thought would be strategies to help contain this. Next slide, please. So then the government got involved. Ex-President Trump signed the CARES Act, the COVID aid relief and economic survival package to help try and figure out how do we mitigate the tremendous financial impact that this thing has had and continues to have. Back in May, we had our first drug that was approved through EUA, which is Emergency Use Authorization. And when we talk about vaccines, we'll explain a little bit more what that is. But that is basically the FDA saying, we're in wartime, so we're going to give you sort of a fast track approval to use different therapies that we think will work for this disease. August, COVID bumped accidents. So coronary artery disease, cancer, used to be accidents was the third leading cause. Now COVID actually is the third leading cause of death in the United States. Shortly after that, as we get through August, CCP, so this is the convalescent plasma, joined the armamentarium of tools that we could potentially use. And even though we've been talking more recently about the variants, the first variant that we saw to COVID happened way back last September. November, BAMLAM, we call it, which is the first monoclonal antibody, one of the more effective tools I think that we have, joined the bandwagon in terms of weapons. Next slide. So Pfizer, toward the end of last year, Pfizer was our first vaccine to come on board. Shortly after that, we did start vaccinations in the state. And in January 13th, just about a month ago or so, the governor expanded the 1A. 1A originally was front-facing providers, so doctors, nurses, healthcare workers, the 70 and olders joined, and then shortly after that, now it's 65 and above are part of the vaccination wave that we're in now. And a little bit later on in late January, first started talking again about variants and what do we need to do about them. South African variant was the first one that was found in the US, and our great state of South Carolina has the dubious honor of being the host to that. February 8th, again expanding our vaccine program to 65 and older. And so that's kind of where we're sitting. So what does this look like so far in terms of cases and deaths worldwide? And again, this slide is a few days old, so these numbers are all a little bit anemic compared to our current reality. But worldwide, over 100 million cases now, with 2.3 million deaths or so in the U.S. And the U.S. is the leading country for cases. We actually account for about a quarter of the cases so far worldwide, and about 20% of the deaths so far worldwide. So we're one of the biggest hosts, about 26.6 million cases, 451 million deaths. In our state, 451,000 cases, a little over 7,000 deaths. And in the county, 13,000 cases, approaching 14,000, and just over 150 deaths. So in the US, what has the cost been in dollars? This is a very conservative estimate in terms of how much business has been lost, how much have we spent on vaccines, how much have we spent on medications, and the increased burden on folks needing our healthcare at $16 trillion so far and counting. So that's just a very quick sort of timeline, hit some of the milestones, and just give you a little tail of the tape of what these numbers look like so far. So I'll let Emily now take it over and talk about some of the therapies that have been out there and are out there now.
Hi, yes, so thank you for having us. This is a virus that we're managing. So we use the term therapies versus treatments because there are no true treatments. There's no cure for this. So we'll go ahead and proceed to the next slide and review some therapies that we're currently utilizing. Next slide, please. So just to remind again that what we're focusing on is prevention because we don't have a cure. I like to use the 3 W's. So watch your distance, wash your hands, wear a mask. It's very simple, a complicated pandemic with a simple solution. Yes, there's comorbidities where you're more at risk. The #1 comorbidity for hospitalized and severe disease is diabetes, obesity, but we can count lots of them. I'm sure y'all have heard about a bunch of them, so I won't go into details on that. And then also talking about isolation versus quarantine. So in a way to continue to limit the spread of the virus, if you test positive for the virus, you are then placed into isolation. The recommendation from the CDC is anywhere from 10 to 14 days. We here at BMH have remained conservative throughout the pandemic, and so we continue to recommend the 14 days. Initially, things have evolved, and CDC came out with the 10-day recommendation. We're sticking with the 14 days. Now, if you're a household contact, you're considered part of that isolation process, but you're then in quarantine. So you're staying away from somebody who has the virus, you have had a possible exposure, and you continue to stay quarantined. And that duration of time varies based on your exposure risk, but again, minimum of 7 days up to 2 weeks. This is kind of a big question, when to get tested, and this can probably evolve a bit. But we talk about if you feel like you have symptoms, to wait at least 3 days and then get tested. If your symptoms are very severe, go get tested when you have symptoms. If you've been exposed to somebody and you're not having any symptoms, wait a week to then get tested. The likelihood of you testing negative early on is very high. So, utilize your time effectively. The nasal swab up your nose, I'm sure you don't want to have more times than you need to. And then also kind of risk and cost as well. So 7 days is a good marker for that. Thank you. Yes, next slide. So our inpatient therapies are focused mostly on supportive care. We talk about oxygen therapy if that's needed. Most of our hospitalizations are requiring oxygen. That's a big marker for inpatient status. We use the term pulmonary toilet. So that means, breathing exercises, focusing on your deep breathing, on expanding your lung capacity, cough suppressants, ambulating to exercise your lungs as well. Proning would be laying on your stomach. So an idea to flip the inflammation in your lungs. So if you're laying on your back all the time, this inflammation is dependent and can increase your pneumonia and inflammatory response. This theory is based on what we've seen with very severe patients with respiratory distress syndrome before the virus. So studies have shown that this has been helpful, and we've adopted that. And bronchodilators are, inhaled breathing treatments to help optimize your lung function. And I would like to say, starting out to a little backpedal, all of what we do here at BMH whether it's inpatient or outpatient that we're talking about, is all based on evidence-based practice. These are guidelines that are coming out from CDC, from NIH, from IDSA, which is Infectious Disease Society of America. So again, we're not a teaching hospital. We stick to the guidelines of what's recommended and what the evidence shows. So three main sort of inpatient therapies. Remdesivir is an antiviral therapy, and it is utilized along with convalescent plasma, which is a blood donation of antibodies, so someone who has recovered from the virus. And these therapies are used in what we call the viral replication phase. So the virus has two phases. We'll use a rough estimate again. Here we are again at 7 days, right? 7 days in the week. But the virus grows in your system as it's mounting. We try to interfere with that response by giving you these therapies that can then decrease how long you're sick, and the antibodies to help you fight off the virus with additional antibodies as you're developing your own. For the second phase of disease, if you will, is the inflammatory stage, where you're requiring oxygen or your symptoms have worsened. Maybe you're having diarrhea, your fever has been resolved, and we will put you on steroid therapy with an oxygen requirement. And this drug is called dexamethasone. The idea with that is to decrease inflammation in the body. So those are, thank you. Outpatient, there's lots that you can do to support your immune system. We can all start now. So there's thoughts of zinc and vitamin C, vitamin D. There's many, remedies from all the different cultures that we have here in Beaufort. I've learned a lot from our Gullah population as well. If there's no harm to it, I say go for it. So I recommend immune support. Where I come from, we also, vouch for Jewish penicillin. That's chicken soup. So keep your immune system optimized as best you can. Anticoagulation. This virus can cause clotting issues. So if you're on, let's say, a blood thinner already, you know who you are, or maybe you take a baby aspirin, recommend continuing to do that. There's no evidence right now that says that we should start you on those therapies outpatient as prevention. So that's where we are with that. Dr. Gambla mentioned, excuse me, the monoclonal antibodies, so the BAM-LAM, as we call it, BAM-LAM-nivolumab, and you may have heard of the Regeneron product, which is a combination of casirivimab and imdevimab. And these two therapies interfere with the inflammatory response, again, to try to help increase how you fight off the virus, to then decrease how much virus is in your system, essentially. And it looks as a copy, essentially, of what your immune system is doing as it's growing. So it's sort of like a carbon copy, if you will. This drug is given as an infusion to try to prevent people from ending up in the hospital. So that's a therapy that we've been providing here. We utilize it in the emergency room, also through primary care. So if you think that you have the virus and your symptoms are worse and you're early on in your course of disease, this is an effective therapy for you. Make sure you talk to your primary care. It's a good option as well. I say at this point, we've given it to at least 120 people, if not closer to 150 now at this point from when we developed. And our hospitalization rate on those patients is low, in the, I can count on my hands. So I think, yeah, is there another slide? No. Excellent, thank you.
Okay, and before we get into vaccines, one thing that we, it's sort of always implied, but I'll say it anyway, easy things that you can do that are no cost, but if we forget about these or shortchange ourselves on these, we always do this at our own peril. So sleep, 7 hours at least a night, sleep, be consistent with that. Hydrate, drink tons of water. Alcohol, unfortunately, doesn't count. And exercise. So 30 minutes a day is all you need to get outside. Get out and get some fresh air and sunlight. I know we always worry about skin cancer, but if you're outside 30 hours a day, the benefits outweigh the risks, getting a little bit of ultraviolet light on you. So those are some other simple, easy things everybody has at their disposal. So we'll just talk again a little bit about vaccines, guys, and about variants. And first thing I want to do is talk about a little bit about the process. How do we get vaccines? Because there has been a lot of discussion, and I think a lot of the cynicism and a lot of the fear of getting these new vaccines as they emerge is that, when you look at how long does it usually take to develop a vaccine, the traditional methods and the traditional process was years to decades in many cases. And now we've gone from concept to first vaccine approval state in a shorter period of time than it takes to conceive and birth a baby, less than 9 months. And so people, I think, justifiably said, how can this be when normally it takes so long? So the answer is because there has never been the concerted effort and the concentration of resources. What has not happened is none of the steps have gotten skipped. So if you see there's preclinical is what technology are we going to be using? So even the mRNA, which are the new vaccines, and we'll talk about those in a little bit, people talk about it like it's new technology. That technology actually had been in development for decades. It was just a technology looking for a great practical application, and now it's found one. But all vaccines go through 3 trials, and I'm generalizing a little bit, but basically we want to answer questions through the different phases. Is it safe? Is it effective? Does it work? And then tweaking the dose and some of the other particulars of it. None of those phases ever get skipped, including with the vaccines we have out now. Once the developer says, we think we've answered all those questions, they have to submit all that data to really 2 advisory boards of the FDA. And these advisory boards are not on anybody's payroll. They're supposed to be nonpartisan, and for the most part, I think are. And their entire goal is to just evaluate the data based on the merits of the data with not any other outside influence or pressure about it. We have to hurry up and get this thing to market. The focus is really on, is it safe and does it work? So that's what happened with the vaccines that we have out now and are coming through. Those 2 advisory committees submit everything then to the FDA. They say, we looked at it, we think it's good, here's how we think this needs to look. And then the FDA approves it. Now, the only thing that's a little bit different is normally the FDA, if they have the luxury of time, they'll say, all right, well, let's do limited trials and let's limit the use of this for years or again, sometimes decades, so we can understand long-term. We get in the short term, yeah, you've met the test. What about long-term? So we don't have the luxury of time to figure this out long-term in this case. So they say, based on the thousands and tens and hundreds, thousands of folks you've had in the trial, what can we extrapolate in terms of side effects and things like that? And so one step short of full approval is this EUA or emergency use authorization. And that's where we say, we have a lot of data. We looked at the data. We think it's good data. The only thing we don't have is long-term data because we don't have time on our side. So we're going to go ahead and approve this with the caveat that we're going to continue to follow the data, and we always reserve the right to pull things or change things or modify things. So that's the process that all vaccines, including the ones we have now, go through. Next slide, please. So Pfizer, that's first one out of the blocks. That's the one that we're using here locally through BMH. And it is the messenger RNA technology. So very briefly, what mRNA technology is this? It is, first of all, there's nothing in there that is a heavy metal, a weird poison. There's no microbots in there. There's no locator chips that the government is having us put into anybody's body. This is really benign stuff. And in fact, is a protein that is found in every cell in our body every day. Our body makes this protein. So what they've done is they've taken this protein and they've just re-engineered it a little bit. So think of the protein as a miniature biologic 3D printer, right? You can make anything with a 3D printer. So what they've done with this is programmed it so that when you inject it in a muscle cell, it says, hey, muscle cell, instead of doing the normal muscle cell stuff that you do all the time, we want you to temporarily, just a small group of you, re-engineer and use this 3D printer. not to make the virus, but to make something that looks like a piece of the virus that the body will recognize. Like, when you see these pictures, these electron microscopes, it looks like a golf ball with little spikes. So just make a spike, and the spike will be enough for the body then to say, that spike doesn't belong here. The invaders are at the gates. Let's call out the cavalry. And that's how the immune response then is activated in the body. So that is a very oversimplified version of how mRNA works. So Pfizer, 2 doses, 3 weeks apart. There's a little bit of leeway, 4 days one way or the other. We say don't consider that your vaccination process done until 7 days after your second dose, so that you've had enough time to really mount that robust immune response. 95% efficacy. So this really blew it out of the water. Most of the time when they are developing vaccines, if you're over 50% efficacious, it probably would still meet the lowest bar for approval. So 95%, I think, surpassed everybody's expectations. The challenge with this is, again, it's got to be very cold chain storage. So negative 94 degrees Fahrenheit, which makes it a little bit difficult in terms of how do you store it, how do you ship it, how long does it last, and all that. So that has been a little bit of a challenge. We have the freezer, so we're able to freeze it at the right temperature, and if we get enough of it, we can get it in larger quantities. We'll take what the state will give us. Talk about that a little bit more later, but we can keep it good for 6 months frozen. So there are a few cautions. Believe it or not, there are no what we'll call absolute contraindications, meaning there's not a group where they've said never use it. They said if you're pregnant, if you're lactating, if you're immunocompromised, talk to your provider. They'll talk you through the pros and cons of it, but all of those groups have gotten the vaccine. Most of them have done very well with that. So anaphylaxis or allergies, that's a big one. Again, we're not saying if you've had anaphylaxis, you can't get it. We're saying proceed with caution. There's an observation period we'll talk about, usually 30 minutes after it. Have drugs ready to reverse it if you do. But again, there have been about, I think the anaphylaxis rate is something like 11 per million or something. So more than flu shot, but still a very, very small number of people that have had anaphylaxis or serious reaction of any kind to this. Side effects are usually mild, self-limiting, and similar to what you would get with a flu vaccine, for instance. Sore arm, muscle ache, headache, might feel crummy and usually these are after the second dose, might feel crummy for a day or two, and that's usually as bad as it gets in the vast majority of folks. Next slide, please. So Moderna, you can see Moderna, except for a few changes in terms of the dose interval, the dormancy, it's a little bit easier to store, but very similar.
You don't have to watch, Chad.
I'll turn it off. I'll turn it off.
All right.
He's got that lisp too. What happened? You got up and he stopped talking.
Huh?
It's the sounds. Oh,
Somebody not on mute.
He hasn't drawn a breath.
There we go. Okay. So Moderna is very simple, very similar to Pfizer. And so for the most part, other than the storage, it's available. I think most folks are going to use it more or less interchangeably. So those are the first two that have been out of the box, both mRNA technology. Next slide, please. All right, so what's coming down the pike? And again, if you want to look at and kind of follow in real time what vaccines are out there all over the world, what stage are they in, and where are they in terms of getting close to being widely available. Actually, the New York Times has a great site called the Coronavirus Vaccine Tracker, where you can sort of at a glance see where every vaccine is in terms of development and who's using it and where in the world. CDC as well, again, has a great website that they update on a number of things around Corona, but also COVID, but also particularly good to follow what's going on with vaccines. All right, next. So what is coming down the pike? The next two we think that'll be out of the box will be Johnson & Johnson, which actually now is actually in front of the advisory committee, so they're taking a look, and we hope by the end of this month that Johnson & Johnson will have EUA, but AstraZeneca as well.
He has a speech impediment or
We
something
think
too.
that J&J, somebody's not on mute. We think that J&J will probably be a little bit less effective, maybe 85% in terms of serious illness and death. But if you're taking all comers, like will you get sick at all from it, might look more like 65, but still I think very effective. The technology is different for AstraZeneca and J&J. They're both similar to each other, but different than Pfizer and Moderna. So the adenovirus technology looks more like the traditional way we would develop a vaccine, which is, in this case, take a cold virus, something that causes colds in chimpanzees, but not in humans, make it weak so we make sure it's not going to harm humans, and inject a very small portion of that virus into the body. Again, the part that looks similar to COVID, and that's how we make our antibody response. So that's what vaccines look like. Next slide. We talked about J&J. So here's the big thing about J&J, if we go back for a second. Two big things about J&J. J&J, you just have to refrigerate. It's good for 3 months. So very simple to store. We think this will be a game changer in terms of getting very large volumes out. And it's one dose. One dose is going to really make a difference, we think. It's been very challenging to get 2 doses in people with the timing and all that. So one dose, we think, again, will be a game changer. So J&J will have 2 huge advantages over what we're using now, I think. All right, next slide. So what do we need to do right now? Well, get the vaccine. That's the main thing. Whether if it's made it through the EUA, I would say get it. Obviously, there's pros and cons, and you can do all kinds of comparison shopping. But whatever you can access first, whether it's Pfizer, Moderna, J&J, AstraZeneca, that's the one you should get, the one that you can get next. When I say act like you never got shots in arms, so one of the big conversations that's going on right now is, so once I'm vaccinated and I'm out my 7 days or my 14 days or whatever it is, can I stop wearing my mask? Can I stop social distancing? Can I act like this was never a thing? And the answer is no, for a number of reasons. First, none of these are 100% effective. Secondly, when we measure does a vaccine work, we're really measuring who's going to get sick from it. We don't know for sure, are you going to still be able to carry the virus and transmit it to others? And we don't know when the variants are coming out, what that's going to look like. So this should be considered, the vaccine should be considered another tool, a great tool, a very reassuring tool, but not a substitute for all the other things we're doing until we get about 80% of our population either vaccinated or I had COVID and I recovered from it. So when I say not the hard way, when we're looking for herd immunity, which is that magic number, in the history of vaccines, in the history of pandemics, just letting herd immunity happen naturally, because there's a question that comes up all the time. Well, eventually enough people will get sick. Some people will recover. Most people will. Why don't we just wait for that and not mess with vaccines? So in the history of viruses, that's never been a good strategy. It takes way too long, way too many people die. And we think that the vaccine response is way more robust, a stronger response, a longer lasting response, and just a better way to do it than sitting around and hoping enough of us survive that it goes away. So that's the strategy around vaccines. And I think, so what are variants? So again, you see on the news now, there's all these different variants popping up. UK variant, Brazilian variant, California variant, South African variant. Lots of discussion about them. Yep, there they are. They all have names and fancy numbers after them, which don't mean that much unless you're scientists following it. Next slide. And actually, these are just the 4 that we've kind of had the most buzz around. There's probably 50 or more variants that are out there. So what do we care about and what do we want to talk about and focus on when we're looking at the variants? Next slide. So we want to know, how do they look in terms of contagion potential, which means take the garden variety COVID back when we only thought we had one COVID. Are the new variants more contagious, less contagious, the same? Right now, the big ones that we're looking at, those four, assume they're all more contagious by a factor of about 150%. So easier to spread. So again, that's why we need to worry about them. They probably do not make you sicker or make more people die. They're right now, we think that, and again, I'm generalizing, and we're still collecting data, but right now we think that they're probably about the same in terms of how bad are they, in terms of virulence. Coverage, again, is going to be all over the map. The good news is, right now, the vaccines that we have out there, we think will all afford some coverage. So it might be, take Pfizer instead of 95%. When you throw all the variants in, it might drop down to 85% and look more like J&J. The good news is there's probably going to be some level of coverage for all these. The other good news is that the vaccines are fairly easy to tweak, especially the mRNA vaccines. So some of this will probably be, if we start to see a ton of activity, for instance, with the UK variant, we'll tweak the vaccine so it may have better coverage. But we're certainly not dead in the water. We're not back at the drawing board in terms of vaccines. We still today have some protection against what we have out there, we think. So that's just a really quick synopsis of variants. Sam, I don't know if you have anything else on that to add.
No, I think the main point here is that prevention is key. So, you know, doing what you can to take care of yourself includes vaccinating yourself. It includes protecting yourself and your community, so we can do what we can to try to end this. You know, so yeah, we're glad to take questions and really appreciate your interest in what we have to share. You know, knowledge is power, and your interest is greatly appreciated.
And I will point out, because some of you may be thinking, well, Gambla just said you're vaccinated, but you should still do all the precautions. So I'm in IR because at least Emily's mask, I'm 6 feet away from her, and the only reason I'm not wearing my mask is because when we did the sound test, I mumble as it is, and so that just made it 10 times worse. So we're still doing several safe things. I'm not wearing the mask because I just quit caring. So anyway, I'll point that out in case anybody's scratching their head and wondering why Gamble's talking about masking and he doesn't have his mask on. Anyway, what questions can we answer for you guys?
Hi, Dr. Gambler. Thank you for coming. And Emily, I have a question from one of the residents, and you spoke to it earlier about anaphylaxis, but this particular question is in regards to his wife had an anaphylactic reaction to an NSAID and wondered if it was still possible to get the vaccine.
So yeah, great question. So right now, anaphylaxis, it does not seem to matter what the reaction was to. Anybody that has anaphylaxis, again, they're saying that doesn't mean you can't get it, but proceed with caution. And so how do we do that? When you come in to get your vaccine, there's a little questionnaire that everybody fills out. If you answer yes to the anaphylaxis question, first of all, at all our vaccinating sites, we have the antidote, which is epinephrine and Benadryl. We also we recommend everybody, whether you have a history of reaction or not, hang out for about 15 minutes so we can observe you. If you have a history of anaphylaxis, that's 30 minutes. So we keep you hostage for about 30 minutes. We have the antidotes right there ready to give if anybody shows a sign of it. But really the only people where we would say absolutely don't get it is if you had anaphylaxis specifically to the first dose of the vaccine. And the only thing in there that you could really react to is the polyethylene glycol, which almost nobody has an allergy to because it's basically what's in Gatorade or what's in Miralax, stuff like that. So hopefully that answers your question.
And I would just add too, to kind of help clarify, is that we say 30 minutes because the likelihood of anaphylaxis to the vaccine will be in the first 30 minutes. So if you don't have a reaction then, the likelihood of you having a reaction that's anaphylaxis is very, very low, if not obsolete.
Yeah, great point, because people worry about delayed reaction. virtually unheard of in any of the trials. It's always been within 30 minutes. That's what they've seen. So that's why we use that number.
Okay, we have another question from a resident. If one has had an organ transplant, such as a kidney transplant, would that be a contraindication to getting the vaccine?
So yeah, when the vaccine came out, that was something that we've researched as well. And as Dr. Gambla mentioned, with being immunocompromised, somebody with an organ transplant, somebody who has HIV, somebody who is currently undergoing chemotherapies, is to, again, proceed with caution. So the societies that then came together, so for like, specifically for kidney transplant, actually for these transplant societies are recommending to get the vaccine, but maybe instead of waiting 15 minutes, you wait 30 minutes, and then making sure that you document if you know your symptoms, and then also to let your transplant team know when you had the vaccine, how you're doing with that. But we do recommend proceeding and getting the vaccine.
Okay. And I have another question. My husband is 71, a cancer survivor, and has recently been diagnosed with COPD. And I'm 68. We both need the vaccine. How do we make this happen sooner rather than later?
Right. So the comorbidities or the other stuff that you have, if you're over 65, that's all you need is to be over 65 now in the state. To get on the list, there's a couple of options. The options, if you want to get specifically on the BMH list, you can just go to our homepage on the internet. There's a banner about vaccine that will kind of prompt you and get you to the sign-up page. This will get you on the waiting list, and unfortunately, it's clunky. This is not our design. This is the state design. So the waiting list will be where you can put all the information in, where then once your number comes up on our waiting list, which is at about 13,000 now, and we get about 1,500 vaccines a week. So again, there is a backlog and will continue to be, but we're working through it as quickly as we can, and we're asking for more vaccines all the time. But you'll get on the waiting list as soon as your number comes up. We'll then send you the invitation and the link to where you can then go in and register through VAMS. That'll get you your appointment and get you into our clinic. Now, there's different parts of the state. You know, at any given time, there might be 100 places throughout the state that are vaccine centers approved by the state. If you go on the DHEC website, the DHEC vaccine tracker, you'll be able to see who's open and who's not. And, you know, sometimes, and this is constantly in flux as people are waxing and waning in a supply. So for instance, Publix might say, you know what, we just got a bunch of Moderna and we're going to open it up. So it's labor intensive because you need to kind of live on that site and keep seeing what's available. But there are some alternatives. If you can get an alternative site quicker than you can get into ours, I would say grab it. And even if you're on our waiting list, then you can always call and say, you know what, I'm on a different, I got it somewhere else, take me off your waiting list. We'll go from there. So again, it's very fluid. You can get in through our site. You can get into any of the sites around the state and get what you can get and get yourself locked in. That's 65 and older right now.
Okay, next question. If after having the vaccine, one were to get COVID, would the illness be ameliorated?
That sounds great. What we know is that the idea with the vaccine is that your likelihood of getting illness is lower, right? That's the intention of the vaccine. But to answer the question about how severe your symptoms would be, they would be less. Because your body already has those antibodies. It's already been imprinted, as Dr. Gambla mentioned, right? It's been identified that this is something foreign. So you already have that fighter cell response. And then you get the virus, your body's like, oh, I kind of know what this is. I've already mounted my fight and I can fight it off. But again, time will tell. With an efficacy rate of, you know, over 90% for a vaccine, I'm hopeful that any disease, if you were to get it, would be very much less severe. I don't want to say minimal, but I'm hopeful.
And another question, since Data is a relatively small community, what percentage of the population here would you think would develop a herd immunity? Or
So-
what number should we see?
Yeah, so I would say I would not think of Data as a sort of a separate entity or an island. And the reason for that is that we really have to think globally on this, because even if you got everybody on Data or almost everybody vaccinated, there are people coming in and out, there are visitors. Everybody gets vaccinated, that still leaves a 5% chance you're not going to get a great response, you're going to be able to spread. So I would not look at it as a Data-centric kind of a picture. We got to think much bigger picture and globally.
Next question. Is there a difference in the efficacy of the vaccines? I have read that the Johnson & Johnson vaccine is about 74% effective.
So in order for a vaccine to get EUA status or FDA approval, it needs to meet a 50% efficacy. I think it's something like 52%. These vaccines are far surpassing what we see. So to give you an idea, the flu vaccine is on average like 40% effective if we're lucky every year. That's why we continue to require repeat vaccination. So they do vary from vaccine to vaccine. The more that we administer them into the population, the likelihood that that efficacy, as the volume of people and the number grows, the efficacy will likely decrease. But we're talking like small percentage points. But yes, Johnson & Johnson, I think when they first came out, it was 85. The most recent trial was a bit lower. Pfizer was around 95. Moderna was right around the same, 93, which is, I mean, incredible that a vaccine would be that effective when really what we're shooting for is essentially half of that to be able to be effective.
Yeah, and you know, part of that too, it gets a little complicated, but some of that is how do you define efficacy? So for instance, we'll take the Johnson & Johnson. There's a 65 number and an 85 number. So the 65 endpoint is you got a 65% chance you're not going to get sick. But really, I think what we have to be okay with right now is, all right, if I get sick, am I going to die or end up in ICU on a ventilator? And so it's 85% you're not going to get that sick, that you're going to die from it or end up on a ventilator. 65% you won't get sick at all. So still, again, compared to a flu vaccine, for instance, it's not a bad proposition.
As a follow-up to that, will yearly boosters be needed, such as we get with the flu shots every year?
We don't know yet. I think that as we see more variants, we may need, a booster sooner than that. I think if we're looking at every year, I think that would be we'd be in pretty good shape if we're looking at annual, booster vaccination. But again, only time will tell as the vaccine gets out into a larger, cohort of people. And yeah, so we don't really know yet. It's a good question. I've been asking it myself.
Is 95% efficacy relevant for seniors? Which you pretty much answered, but.
Yeah, so the vaccine was actually studied in how do I say this? Like no special population. So they didn't look at, that's why we say proceed with caution. Like it wasn't studied specifically in immunocompromised or specifically in seniors, specifically in pregnant. So it's, across the board, that's what we're seeing. And the cohort was 75,000 participants. These are people that are signing up, holding their hand up and volunteering to be part of this trial. So we were able to look at a big cohort. I mean, anywhere from age 16 to like, I don't know how old this one, but it was over 90 years old. So yeah.
Okay.
Yeah, and that 5% that it doesn't hit, I think that's where the research is focusing now. So if you're in that 5% where you didn't get the effect, what was it? Was it because of your age? Was it because of some other underlying condition you had? What made you an outlier? And that's what I think will fuel the next generation of vaccines in terms of, all right, let's see if we can shoot for 99%.
Would you have a prediction as to when we might get back to life that we call normal?
I don't remember my life ever being normal. So you mean our previous baseline? Is that?
Yes, yes.
I think there's so many variables in the equation. It's hard to speculate. I think that we're certainly moving in that direction. There are glimmers now as we're starting to see, at least locally, some of the numbers come down. Hopefully we're not just coming off of the Christmas, New Year surge to then see in a couple of weeks a Super Bowl surge. Hopefully it's just now we're finally starting to see the natural course of this thing start to abate a little bit. Certainly the vaccine is going to be a big wallop to it and help us move whatever that timeline was going to be along. But I think it would be premature and irresponsible for me to say September 13th, 2022 is going to be the everyone can come back out. I don't know that. I don't know, Emily, if you have if you're reading the tea leaves any better than that. But.
Yeah, I got that question when this all started, honestly, and I kind of get this, I don't know, nickname of being sort of the in-house wet blanket that I get to bring bad news often because I wish that I could say that, we will get closer to that place. But I would say unless we need 80% essentially of the population to be immunized or have consistent immunity to then stop masking, which is what people are asking. And it's going to take us a while to get there.
We're at about, that number right now is, I think, 3 or 4